Afternoon. I think as part of the ground rules, may I ask everyone who's not presenting to please mute their mics? I could do that on my side, but I'm actually not able to do that right now. So please mute your mics if you're not presenting. Thank you very much, colleagues, and welcome this afternoon for this really important session that we are having. We have called it a learning and a knowledge sharing experience, and rightly so, because we'll be hearing from our colleagues from Italy on how they have been able to support especially around mental health and psychosocial support during COVID. We've discussed, especially yesterday, about some of the challenges around implementation, and maybe if we can just hear slightly more from them later on in the call. As an introduction, my name is Teresa Ombalo. I chair the Mental Health and Psychosocial Support Technical Working Group here in Ethiopia. And I'm happy to have you all on board and looking forward to a good learning session. And I think I will ask Adele to kind of, she'll be, now she's recording the session and also is also able to mute and unmute participants. So if it's your turn to present, I would ask Adele to just unmute you or go ahead and unmute yourself. So thank you for being with us for the next 45 minutes. And I'll hand over to Adele to proceed, please.
Hello, everybody. Good afternoon. So I have started the recording and I don't have anything to present, but the first presenter can go ahead with the agenda. Laura, can you maybe help us with the first presenter?
Adele, if you could unmute Laura. Oh, she's saying she's facing some technical problems.
Teresa, if you have the agenda, we can call the first presenter.
All right, just 1 second. Laura, can you hear us? Sorry, just one moment.
So my colleague Laura is going to close the meeting for herself only and come back again because she's having some trouble with the audio. But I think the first presenter could be Dr. Gerolamo. Can you hear us?
Can you hear me?
Yes, we can hear you.
Yes,
Okay.
we can hear you.
Adele, can you please show my slides because I'm unable to do it here. Can you do that?
Absolutely. Here they are. See them?
Okay. Can you? Okay, that's fine. I will have a 10 minutes brief presentation. Let me present myself. I am now full screen.
Yeah, sorry, I just wanted to close this.
Okay, I am a psychiatrist working in Brescia, which has been one of the Italian cities most affected by the infection. However, I have to specify that I am currently not involved directly in clinical activities because I am the head of psychiatric research in my clinical research center based here in Brescia. Next, Adele. In Italy, Italy is currently, this is not updated to now. We have now almost 280,000 cases of COVID-19 positive people with over 30,000 deaths, mostly concentrated in the north of Italy, in the Lombardy region where I live. Next. There have been more than 200 physicians caring for COVID patients who died since the start of the epidemic. Next. I have published about a month ago a paper in JAMA Psychiatry with a number of colleagues from the region who have been involved directly in the management of departments of mental health during the COVID. Next. And we have also published the paper, which is probably the first report ever published, showing next. Okay, it's a study done in 4 catchment areas for almost 1.4 million inhabitants, including 7 general hospital psychiatric wards. Next. And as you can see from the dotted line, we have demonstrated that from the beginning of March up to the end of April, in 2 months, compared to the previous months and to the same months of 2019, there has been a 50% decrease in voluntary hospitalizations, while there has been no change in compulsory hospitalizations. Next. There have been a number of papers studying admission rates during major disasters. For instance, these are 2 papers published in the 60s showing that during World War II, there was a significant decrease in the number of psychiatric hospitalization rates. And after a number of years, these rates went back to the same rates as before the war. Next. There have been many studies inquiring which was the admission rate after major disasters. These are some of these studies. But next, I want to show you, I want to draw your attention on a particular study done by Bob Rosenek, who is an outstanding American psychiatrist. Bob Rosenek and his colleague, they studied mental health service use in 40 American cities, including the New York City area, after the famous September 11 terrorist attack. Next. And interestingly, they didn't find any increase either in outpatient or in inpatient service use for any psychiatric disorders after the terrorist attack of September 11. Next. There have been a number of studies assessing the psychosocial sequelae of the SARS epidemic, and also a couple of studies on the MERS, but there have been no studies focusing on psychiatric hospitalization rates. Next. An interesting study was published in 2011 in Schizophrenia Bulletin, pointing to a possible increase in psychotic first episodes associated to positivity to coronavirus immunoreactivity. And so this is a phenomenon which we may study in the coming years. Next. In Toronto, during the SARS outbreak, they found a significant decrease in hospitalization rates to any medical and surgical wards during the epidemic. Probably this is one of the explanations of our own findings. That means that people are afraid of hospitals because they see the hospitals as a place of possible contagion, and so they stay outside of hospitals. Probably there is also a change in thresholds for behavioral problems leading to psychiatric hospitalization. So for a variety of problems, we may face a decrease in hospitalization rates in many countries, and we are planning to study this in many European countries. Next. Okay, in Italy, there was a paper published about a month ago in the New England Journal of Medicine, which is, as you know, the leading medical journal, internationally speaking, and they found a very strong decrease in hospitalization rates for acute coronary syndrome, again, probably due to the fear to go to the hospital. And one of the effects of this delayed referral to hospitals is that these colleagues have seen an increase in death rates among people hospitalized for acute coronary syndrome. Next. I'm going to finish. So this is an historical paper published as early as 1919, talking about the famous Spanish flu epidemic. So the problem of the health consequences, next, the health consequences of the epidemic on mental health services and on psychiatric patients have been for many years a matter of interest. Next. This is a very interesting paper published in Nature Human Behavior. It's probably, in my opinion, the best theoretical paper discussing, as you can see, psychosocial and behavioral problems associated to the COVID-19 epidemic and response. Next. Of course, if some of you is interested in these papers, I'd be happy to send it to you. These are two papers included in the Nature Human Behavior paper. Next. We have been in the past involved in the World Mental Health Survey Initiative, which is this large epidemiological study that involves the assessment of Next. 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 Go on, please. Go on, please. Go on, please. Okay, I just want to finish drawing your attention on an. Go on, please. A very important point, which is very often misinterpreted among mental health professionals, is that debriefing applied to all population exposed to a traumatic event is not indicated, but is contraindicated. So the majority, fortunately, the majority of people exposed to any types of trauma are not
Sorry, Giovanni, may I ask colleagues to kindly mute your mics? There is too much interruption.
okay. I think that I have finished. Thank you
Please
very much.
mute your mic.
I finished.
Hello, colleagues, may I kindly ask you to mute your mics if you are not speaking? It's really causing a huge interruption and we are not able to hear the speakers. We all agree that this was an important session for all of us. Please just mute your mic if you are not speaking. There is too much noise coming from the background. Kindly mute your mics if you are not speaking. Sorry, Dr. Giovanni, we did not quite hear your last slide presentation, but if you could kindly share those with us, then we will be able to probably digest them later. Thank you very much for the presentation. And I will give this opportunity back to Laura. But before that, if there are any questions for Dr. Giovanni, any clarifications that maybe from the experience of Italy, and we need to know how they handled some matters, kindly just raise your hand. Adele will see you and give you an opportunity to ask your questions. Yes.
Teresa, just one thing. Maybe, Dr. Giovanni, you have to finish your presentation. You have still some remaining slides. Do you want to go on, or for you is enough?
Let me just clarify the last point that has to do with the briefing. The briefing should not be applied extensively to all populations exposed to a disaster, to a traumatic event. So, as WHO recommends, there should be close monitoring, and only people who have specific risk factors and display initial symptoms of suffering, psychological suffering, of anxiety or depressive symptoms, acute stress reactions, should receive an intervention. The only psychological interventions for which there is proof of evidence, as you may know, are cognitive behavioral therapy and EMDR. I think that I've finished.
All right. Thank you. Go ahead, Laura.
Just to say, maybe after all the questions and of all the three presentations, we are going to have a discussion, an open discussion, or you prefer to have one by one?
Sorry, Laura, your line is really breaking and we cannot hear you clearly. But I thought maybe we could have the questions right after the presentations so that we do not forget them. For example, there's already a question on the chat box for Dr. Giovanni. on how did Italy handle the treatment of patients with psychiatric illness in addition to COVID-19 infection. How did Italy handle the treatment of patients with psychiatric illness in addition to COVID-19 infection? Dr. Giovanni, please.
Can you hear me? Can you hear me? Hello?
Yes, we can.
I think that the best person for this question, the best respondent is Dr. Starace, who is in the discussion and he will follow later. So I think that he's in the best position because he's the head of a large department of mental health with thousands of patients in treatment. And so he's the best person to reply.
Thank you, Dr. Giovanni. We will stand by for his response. Because Laura is having some technical difficulties with her connection, I will go ahead and introduce the next speaker, who is indeed Dr. Fabriasi, to talk to us about restructuring, services restructuring in the face of COVID-19 emergency operations. So, Dr. Fabriasi, please.
Thank you very much. Can you hear me? Is that okay?
We can. Thank you.
Okay, so I'll try to summarize in this presentation what have been the instructions for mental health services we issued as the Italian Society for Epidemiological Psychiatry. These instructions have been taken by the Ministry of Health, and with some integration they have been issued to all the Department of Mental Health around Italy. Okay, let's go ahead. The principle is that taking responsibility, public health responsibility, to keep the network of community psychiatric services operational is an ethical imperative. Also during the emergency caused by COVID-19. And therefore it was necessary to share procedures that can be implemented in the entire country. The aims were to reduce the spread of the disease within mental health outpatient and inpatient services, but on the other side, to guarantee during the health emergency the best healthcare possible, taking into account both patients' needs and the safety of procedures. There is one background thought that I want to share with you regarding the higher risk severe mental illness patients run during the COVID-19 epidemic, because it's well known that this population suffers from higher rates of respiratory diseases, and around 15% of patients currently treated by community mental health centers had at least one admission to medium and long-term inpatient facilities during the previous year, with the consequent associated risk of acquiring nosocomial respiratory infections. So let's go to the instructions regarding, first of all, outpatient activities. All the activities were reorganized, calling patients receiving their appointments to check if it was possible to replace scheduled outpatient visits. The nurse assessed through the phone call to the patient or family members the patient's physical health status, the mental health status, concerns about the current situations, changes in clinical symptomology since last assessment, and also the health status of family members was checked. The phone call was also the occasion when the professional provided information about the open hours of the services, the change in access to the service, and public health recommendations about limiting social contacts. There were a number of reasons why the scheduled appointment was maintained. This was when a critical clinical situation was assessed during the previous visit or the phone check-in, when there was the necessity to directly administer pharmacological therapy, or when legal obligations were issued on the patient. On the other side, scheduled appointments were postponed if the clinical situation was stable, the patients showed pre-existent vulnerable physical health conditions, a good adherence to treatment was ascertained, a supporting family network was present, and of course, if the patient expressed a preference to postpone the appointment. With regard to the organization of outpatient services, professionals working at the front desk wear the fluid-resistant surgical mask, had alcohol-based hand sanitizer, and had constant access to products for wiping hard surfaces. Before entering the building, users received instructions on how to use hand sanitizer and were redirected to the triage area by dedicated signs. Users were also asked to fill out a risk assessment form to check their current health conditions. Each center has been asked to ensure a clear path to access the building and guide the users from the triage zone to the waiting area. Here, social distancing was guaranteed, and this means that the number of people allowed was carefully monitored, removing chairs, removing all other things in the area. And outside the triage area, signs reported the new procedure for access and remind the users about the need to maintain interpersonal distancing while in line. Okay, that's it. Of course, group activities were suspended, and as an alternative, individual therapy sessions or family meetings were provided. Meetings as well were suspended, and if needed, were performed through telemedicine tools such as video call. In-person meetings preceding discharge from inpatient units were performed following the same directions provided for home visits. And what about home visits? Before performing that, mental health professionals were asked to take all the steps to minimize the risk of transmission through safe working procedures. Mental health professionals were also asked to wear a disposable apron, gloves, and fluid-resistant surgical masks to maintain a minimal interpersonal distance. And if the patient showed symptoms, shortness of breath, for instance, a fluid-resistant surgical mask was provided to the patient. Day hospitals and day centers activities were suspended because they favor large gatherings of people. If it was not possible to suspend, a drastic reduction of access to activities was enforced. When suspended, the lead provider organized an alternative therapeutic program for each patient in charge. With concern to residential care, new admissions have been suspended. Exceptions were adopted for selected cases, for instance, as an alternative to hospital inpatient admission or intensive outpatient psychiatric treatment, for instance, those following a recent inpatient hospitalization. In any case, the physical health status and possible at-risk contacts were assessed. If the check was positive, in other words, if the symptoms were present and the admission to the unit was deemed necessary, the patient was admitted only if the facility was able to provide a room for isolation, personal protective equipment, and a screening test. Along their presence in residential care program, individuals were offered educational sessions, encouraged to correct hand hygiene, and daily or 2 times per day body temperature and respiratory rate was checked. Visitors were not allowed to the building. Only exceptionally this choice was made by the director of the unit, and hospitalized patients were not allowed to go outside the unit. Finally, with regard to inpatient units, new admissions were limited to clinical emergency, those which couldn't be deferred, for example, compulsory admissions. In any case, a complete check of health status and at-risk contacts was made. If the check was positive, the same applied as I told before. The facilities should have rooms for isolation, screening test, personal protective equipment. Patients during their inpatient stay were offered individual educational sessions. Visitors were not allowed in the building, and hospitalized patients were not allowed to go outside. Just to sum up some of the critical aspects we took note, we observed a substantial reduction of ordinary care delivery. Psychiatry, telemedicine was implemented very quickly, and so telephone calls and video calls were very largely adopted. but notwithstanding, we found several difficulties in ensuring continuity of care. We had also, especially at the beginning of the epidemic, we had a shortage of PPE. We had also infections in mental health professionals. And we saw that isolation of infected patients in acute or residential facilities were not always performed. This happened especially in the first phase of the epidemic. We also observed the difficulties in admitting patients with severe mental illness in infectious diseases wards. Also providing psychiatric support. One point of the guideline stated that also patients with severe mental illness and COVID positive had to be treated in infectious diseases wards with psychiatric support. In some parts, in some regions of the country, several psychiatric wards specifically dedicated to COVID positive patients were open. And finally, we should not forget the need to provide practical and psychological support to health professionals, COVID patients and families, but on these aspects, the next speaker will go in depth. We observed a substantial decrease in hospital admissions, in the number of community mental health services patients, and also in the emergency visits for psychiatric problems to the hospital. What about the future? We are now facing a decrease in the rates of epidemic, but an increase of the socio-economic consequences of this crisis, which is becoming from an infectious disease crisis, a socio-economic crisis. And we also worry about the possibility of new outbreaks. So for both and many other of these considerations, we should be prepared, learning from our experience. Thank you very much.
Thank you very much, Dr. Fabrizio, for a very excellent presentation. It's keeping us thinking and jogging our memories on what we need to do next, not just for COVID, but after COVID infections. I would like to encourage my colleagues to please note down your questions, and then we will take them after the last presenter, who's Dr. Maria, and who's going to talk to us about stress management for healthcare workers. Please let us note down our questions. We will take all the questions after this presentation. Dr. Maria, please.
Thank you. Can you see my presentation?
I can, and I guess the rest of us can too.
Okay, thank you. For all of you that do not know the National Institute of Health, there is this brief introduction. The National Institute of Health is the leading technical scientific body of the Italian National Health Service, and performs research, control and counseling on public health, either for the Ministry of Health and the regions. And during this SARS-CoV-2 emergency, we have been appointed by the government as a member of the Scientific and Technical Committee, and to decide actions, procedures to face with several issues related to the emergency. Immediately, we prepared several working groups. One of them is the one on mental health, where Giovanni and Fabrizio and I are belonging to. And we are preparing report to face several problems related to the emergency. This is the rapid evolution in Italy of the SARS-CoV-2 emergency. We started with the first cases in Rome in the middle of January, and in the middle of February we had another case in Lombardy region. On February 21st, we had the first lockdown in some municipalities in Lombardy and the Veneto regions. March 8th, the government extended the coronavirus quarantine zone to cover several regions in the north of Italy. And on the March 9th, the government of Italy imposed a national quarantine, restricting the movement of the population all over the Italian territory. We got until, this is an update of May 25th, we got until now over 230,000 infections of COVID-19, and 12% of these are among the health workers. As you can see here, the infected subjects within the health workers are in the age range between 30 to 60 years old. And the only data collected on the health workers that died during this period are the one collected here. We got 164 frontline doctors, 14 nurses, and 21 care workers. But we are suspecting to have more cases of health workers that died for this infection. As you can easily understand, the health workers experienced a specific critical situation of discomfort and with the limited possibilities of resolution. And the very rapid evolution of the pandemic and the consequent progressive updating of national and local operational indication has made it necessary to continuously modify the strategies implemented, in particular in the areas with the high COVID prevalence. So entire health facilities have been reorganized and completely dedicated to the COVID-19 emergency, different activities, different procedures, and the health workers had to change teams, workplaces, and they had also to face with changing their modality to relate or contact with patients, relatives, and family members, and to find different ways to recover energy, both physical and emotional. As a consequence of the emergency scenario, they had to face with several stress factors, not only the direct exposure to biological risk, but as Dr. Starace was saying, also the initial generalized difficulty in finding the PPE and the excessive workload and lack of rest. They had to manage with the complex patients, and at the beginning, but also now, also to face with the lack of treatment of proven effectiveness. They felt vulnerable. They felt concerned about their health and also to spread the infection to their family members. For this reason, some of them had to face with the lack of contact with their families, with the problem of having difficulties in sharing work-related emotions with them, and in the interruption of relationship with their son, and so on. For this reason, our working group on mental health decided to prepare a report for the appropriate support of health workers. And we started with identifying and reviewing international experiences, adapting these experiences and evidences to the Italian context, and to develop and disseminate public health policies. These are the COVID contents is a specific section on our website where you can find all the evidences collected every week on the published during the past 3 months at the international level. And in the past months, we started a strong collaboration with the main mental health centers in China. And as you can see here, we asked to the Cochrane Center to translate the guideline for psychological adjustment during the COVID-19 pandemic. We have an Italian version right now, and we updated these evidences and best practices to the Italian context. These are the section in our website where you can find all the safety instructions based on the Italian scenario. We also developed some training, also distance learning training for health workers, different kind of professionals, and not only people for example, dealing with performing the rhinopharyngeal swab, but also people with that had to manage with the dead body and so on. And also together with the Italian scientific community, we are developing a sort of best practices for specific disorders. This is the paper of Giovanni De Girolamo and Fabrizio Starace, and also the Italian guidelines for the Italian Society of Psychiatry. In the report, there are practical and operative procedures, and that should be implemented according to different needs related to the pandemic. For example, in Italy, we had a different level of local spread. As you can see here from this little image, the north of Italy was more affected than the center of the south of Italy. And also taking into account the different professionals, personal and context elements that can determine a greater risk for distress of workers. I will try to go in more detail, but in just few days, our report will be available in English, and I will send to you the link, and you can better read, not only in 5 minutes to have all the information. And basically all the people that are responsible for health and social care facilities, they should maintain an effective, clear and regular communication flow between the top management and the individual and the professionals operating in the different operative units. They should organize workspace and time to avoid, as far as possible, protected work overloads, and trying to ensure for them breaks and rest periods. Encourage sharing and teamwork, because we know that promoting collaboration and communication between workers is producing a reduction of the sense of isolation and the reduction of the stress. And they should favor homogeneous practices between operative units, for example, how to manage the communication with patients and relatives. We also know that the lack of knowledge of appropriate measures to reduce the risk of infection is increasing the risk of suffering of physical and mental health issues. For this reason, all the hospitals and different kind of residential or non-residential structure, they should give the possibility to all workers to receive an appropriate training to reduce the risk of infection, but also to provide adequate adaptation and recovery strategies. As I was saying before, we provided distance learning on infection prevention and control to different kinds of professionals. We have also available technical reports to guide professionals, for example, on how to use protection device, the collection, storage, and analysis of the different swabs for checking the infection, and so on. And also we have available on our website all the best practices and the guidelines produced by the scientific society. It's also important to provide the material support. The availability of this material can strongly help in reducing the stress load on workers. For example, to provide them with the personal protective equipment, also to provide them with places to recover or rest in the work context, to supply them with the basic necessities, for example, food and drinks, to have the possibility of dedicated housing to avoid returning at home, or for example to manage isolation when they get infected, special support in the management of their children, and also some regions, for example the Emilia-Romagna region, prepared a sort of economic awards for health workers working in the front line. And one of the most important things is that managers of the health and social care facilities should promote an environment that fosters communication and the social support. So here are illustrated the different kind of strategies, for example, to provide individual support strategies such as nutrition, to have a light and nutritious diet, to have a restful sleep, to meditate or deep breathe, to reduce their anxiety, enjoying relaxing music, to have the possibility to share with the working group your emotion. And it's important also the monitoring of reactions relating to the discomfort, to keep track when your collaborators have poor or excessive appetites, or they start to have a poor quality of sleep, and so on. Of course, when they have problems such as stress-related pathologies, they should activate immediately psychological and psychiatric support. For example, the Italian Society for Psychiatry also activated a free number where all the operators can talk and express their discomfort, and they are immediately directed to the local mental health department in case they need more support. A specific support, this is important to note, should be devoted to, for example, female workers without any support for the management of children, because they really felt absorbed by their work needs, and at the same time they were without any support for the management of children, without the possibility of exercising their role in supporting their children or managing, for example, the school at distance. So in these cases, for example, the government provided them with some money, specific bonus for the babysitting, or services where they can bring their children and someone is taking care of them. And or some professionals are faced with symptoms of distress and depression, or also they faced with emotional fatigue in managing the death's communication. In this way, in this case, they have been supported with specific training. They've been provided with video calling technologies to have the way for these people to talk with their relatives, and also to provide them with the way of communicate with the others, because these produce a stronger reduction of stress. And another specific support should be devoted to the health workers COVID positive that were in quarantine, but also the one with relatives infected. In this case, proactive stress management intervention and psychological support should be provided. This is the end. This is going to be our report, and you should find here. This is the website where you can find all the reports also in English. And as I said, in 2 days, you can find everything online. Thank you for your attention.
Thank you, Dr. Maria, for that very, very informative discussion. We really needed to hear that, especially for the colleagues that are working in quarantine facilities. And with that presentation from Dr. Maria, we come to the end of the presentations. And now I would like to open the floor for any questions. A few have been put on the chat box. As I try to go through them, if there's anyone who has questions that they have not put in the chat box, to kindly go ahead and ask. But to come back to the first question that was asked, let me see if I can find it. Yeah, that was a question that was asked earlier on. How did you handle the treatment of patients with psychiatric illness in addition to COVID-19 infection? I'm not sure who among the three presenters, Dr. Giovanni, Dr. Fabrizio, Dr. Maria, will take that. But how did you manage to support patients who have psychiatric illnesses and also COVID positive? Over to you.
I may try to introduce the subject. In actual fact, we had this kind of situation, especially in patients who were in residential facilities or in inpatient units. And as I told you, when the logistic was favorable, we tried to divide the facility in a sort of COVID area and COVID-free area, planning two different paths to access and of course dedicating personnel specific to these patients. In our practice here in Modena, we had very few cases who were managed this way. In other parts of Italy, the situation was quite worse, with numbers of patients with COVID infection, and so the health authorities decided to dedicate an entire ward with 15 beds to infected patients. To me, this could be an extreme decision, of course, depending on the epidemiological situation of the area. Fortunately, this solution was needed only, as far as I know, in 2 or 3 cases all around Italy. In all the other cases, we tried, if psychiatric conditions were allowing a management in general infectious diseases ward, simply to support our colleagues with psychiatric nurses and of course ensuring psychiatric consultation on daily basis. And this has been the way we manage. A different view, of course, is on outpatients having this kind of problem with the infection, along with their with the interruption of outpatient visits or day center programs. In this case, we try to implement home visits, of course, providing healthcare workers with all the necessary protective equipment. But as far as I know, this situation has been very rare, and so it was quite easy to manage it without a big problem.
Thank you for that response, and that clarifies a bit, because it has been a concern for us here, even as we are talking about continuity of mental health care, how we will continue to support those in long-term residential facilities for mental health. And in case they get infected with COVID, how do we move on to still support them? So thank you for that clarification. And I think my colleague who asked that question, we have very well noted it. There is also another question that was raised by one of my colleagues. When the outbreak began, especially in China and then later on to Europe, there was a misperception or misconception that it only affects the older generations. And the question here is, did you see any new cases or a rise in young people getting infected more than was originally thought? What has been your experience in Italy with the younger population in terms of infections?
I'll try, but of course, Maria Luisa and Giovanni are most welcome to intervene. I'm sure that Maria Luisa will cover the area of young and adolescents. Just to add that I didn't see any specific increase of young adults' psychiatric problems related to COVID-19. So this was not a problem for us. The good side of the medal has been that young patients, young adults in charge on community mental health centers were those more familiar with telecommunication, video call, use of internet. So it was quite easier to maintain a contact with them, also with the adoption of these new technologies. One of the positive effects of this epidemic has been that in a couple of months we have jumped towards telepsychiatry, doing what we didn't do in the 20 years before. In 2 months we covered a gap which was really large. Maria Luisa.
Yeah, I don't have so much to add with respect to the data collected in China, in the sense that looks like also in Italy we have the a bigger number of infected people over the 40 years old, and the same lethality in people over 60 years old. And we do not have a lot of serious problems in young people lower than 18 years old. So also our data show that they are not experiencing or facing, for example, the hospitalization. Not a lot of them, but we also have checked their viral power, as I don't know how to translate the correspective of, no, they got infected, they are infected, but in any case, they are not experiencing a serious problem. So nothing is changed also in our data in respect to the one from China.
Thank you very much. I think that's good to know, but also that doesn't also just pushes us to do more work with the young people, because we know that the infections can still happen, although they have more of a fighting power, but still it's we say it's better prevention than treatment, because obviously there's still no treatment for it. So thank you for that. And I think here, even as we look at the data that is shared with us on a daily basis in cases in infections, I think it really is falling within a broad spectrum from as young, I don't have the age right now, but from the youngest that we've had, I think it was a 9-month-old baby. I'm trying to find the data for that. When I find it, I'll probably share it. So it really does range. It's not to any specific age group. So then the next question in terms of that is that because of the restrictions put around the prevention or social distancing for COVID, people are wondering, how do you support families that have lost a loved one and are grieving and yet cannot use the normal grieving processes that maybe that they're familiar with? How do they deal with that in Italy? Also, it's things that we can adapt or just help the people that we are working here with. Dr. Maria.
I don't know if Fabrizio wants to say something about it, but also in our working group, we are talking a lot about it. And Fabrizio is part of the national, I don't know how to say, translate in English, but health sector. And I know that we are dealing a lot with these mental health problems, and a lot of also professionals working on the mental health are trying to face with this situation. We are really thoughtful about especially the familiar that had to grieve these the familiars, the relatives without any sort of contact. They are just having their relatives in the little box and without the way of saying anything to them. And I know that a lot of mental health professionals are trying to provide the support. There are also a lot of toll-free numbers to call, but I'm sure that Fabrizio can say more about it.
Yes, we displaced the entire psychological teams, especially in the general hospital or in the COVID hospitals, where this problem was so felt by everybody. It was these teams worked specifically with each family member of people died and this was a very important support they provided, taking care several cases also with longer follow-up with these people. In addition, we provided the general population with the possibility to contact a psychological by telephone, a psychological help. And when the professionals devoted to these services assessed the clinical evident problems, they suggest people to contact clinical teams both in the hospital and in the community, providing them with necessary information, contact numbers, and so on. So this is a really burning issue that has been addressed this way.
Thank you very much for the further clarification. Yeah, it's not the easiest thing to deal with at this point when you probably will not have all the support system around you that so many of us are accustomed to. So we have to look at alternative ways of being able to support. You may already have answered this question before, but to just kind of the question was around provision of mental health psychosocial support services, and also for people infected as well as their families. So I think we talked a lot about telehealth and other avenues. I don't know if you wanted to add anything more on that, on how to support people that are infected, their families, those who are in quarantine. I don't know if you because especially here in Ethiopia, we have a lot of people in quarantine since the government regulated that or mandated that. And people are in quarantine waiting for their results to come in. And then when they're tested positive, then they move on to isolation and treatment. How to continue providing mental health support while keeping our healthcare workers and our psychologists safe.
In our experience, there is a public health team who calls people in quarantine on a daily basis, and together with the symptoms and clinical situation, they also assess possible psychological reactions on that. If they find there is something unusual or in need to be assessed more in depth, they ask the permission of person to be contacted by the other team, which I mentioned before, the psychological. I want to address also your point concerning the situation of not so widely diffused community mental health teams. I wouldn't forget the importance of community health, especially in communities where ties are long-standing. We have had also here very good experiences with associations of people taking care of practical and emotional needs of other persons. For instance, going outside to buy food or to bring them medicines if needed, and also taking care of social contacts. Social contacts can be maintained also by telephone, and especially when a person is isolated in quarantine, it's a good thing to have somebody to speak also for 10 minutes just to express the emotions and all the things that are passing through your brain. So it's a very important but informal, I would say, way to express support by the
Thank you. I think that's really important. Having been in quarantine myself, when I first came into the country, I know how important it is to just get that phone call to check in on you, talk about everything else and nothing in particular. That really does help. So I think that's really important to consider even as we progress with our work here. So maybe the last question, and then I will ask Adele or to just take over, or Laura. From me, there was the last question, I think you can say, Dr. Fabrizio, is on supporting healthcare workers who have children, because that has been a big concern, and most people have actually sometimes chosen not to respond because of the fear, like we talked about when Dr. Maria was presenting, fear of infection, fear of infecting others. How to go about supporting the healthcare workers to just be able to do their job as it's really, really needed, but also continue to protect themselves and their families. Fabrizio, please unmute yourself.
I wonder if Maria Luisa want to add something, but she pointed out the two very important points. Having a practical support can make the difference in these cases. If you have to work from 8 in the morning to 8 in the evening, and you have to take care also of children at home, you need somebody who goes around to buy foods or basic things. And maybe if you have somebody else taking care of children, you can deal with your fear to transmit, to possibly transmit the infection to your children by sleeping for some days in another place. We put together this opportunity in some cases, and I personally found people thanking for that, saying that this was a sort of unexpressed fear, but many of them chose to sleep for some days somewhere else, so to be quiet, so to not to be stressed by the idea of transmitting the disease to children, or maybe to grandparents who are more vulnerable to the bad consequences of infection. So these are the 2 points, the 2 main points that Maria Luisa made. Yes.
No, I agree. I perfectly agree with Fabrizio. So the most important thing was that the managers, the directors of these structures and the organization just were speaking with these mothers and fathers worried about going back at home, and also saying to their very young child, please don't touch me, please stay away. This was very, very difficult, and in most of these cases to have another place where to rest, avoiding to go back in their homes and to face with this horrible situation. They really prefer to stay away, and this helped them a lot. And also the fact that the government provided this money to have the possibilities for them to cover the expenses for people that were taking care of their children, and they felt supported. They already felt that the government, the directors, the managers were taking care of this important part of their lives.
Thank you very much. I don't know how much more time we might have with you because the questions keep coming, obviously because of the interest and just the practicalities of what we are dealing with here in Ethiopia. As you can see, there is a question on the interaction of psychotropic medication and COVID-19. I don't know if you had any experience with anybody who was on psychotropic medication and was positive and had to be put on medication for managing COVID, and how all that played around.
Sorry, Teresa, I missed the point because I was looking at the at the chat, the very long chat with several questions. Was the questions related to the pharmacological management, psychopharmacological management of both the infection and the psychiatric problems?
Exactly. So the interaction, was there any effects or side effects between the medications and COVID? Yeah.
From this point of view, we had a very important help from one of the leading scientific group in Italy, from the University of Verona. They very quickly made a comprehensive review of the interactions between psychopharmacological drugs and medicine, the most widely used medicine for COVID-19. So we had this very important help, and with a very simple table, we had at glance all the possible interaction to monitor. And of course, we had to decide for the best balancing the interest to taking care of one symptom or another.
Thank you. Sounds like a balancing act that you almost have to make on the spot to decide which way to go. So, but that would be interesting. I don't know if you can share that, especially to our colleagues who are supporting the psychiatric patients that need medication, and also so that they're aware that probably these are the some of the interactions. And of course, we'll also look in-house for some of the materials that we have, because we are working closely with the universities here, and we can't be able to ask for their support, but also just learning from your experience, I think is really good. So thank you very much. And of course, in Ethiopia, like in the rest of the developing world, there's the challenges of working without internet connectivity. For example, in some parts, we are having to work with people in refugee camps or internally displaced people, where sometimes the services are not as efficient as in other cities, for example, here in Addis. So there is just the thinking around how best to support the people in those fragile environments, and just to keep everybody safe. And I'm not sure if you had an experience with that. I know probably there's issues of migrants in Italy, and was there any issues about such large numbers of people around that?
There is some of these experience in settings, in very difficult settings. I'm not aware of that mentioned in the question. But for instance, another of these settings is jail, is prison, and it would be worth mentioning that at national level, the government adopted a policy to recruit 1,000 all over Italy professionals specifically displaced in prisons to help professional working inside to deal with problems related to COVID. In particular, with the psychoeducational sessions, because fortunately the infection didn't spread so much in prison.
Thank you very much. There's a question that has been asked twice. I guess it's really important for the for us to kind of get a response, and you may have answered it in another way about health advocates in communities, and did that make an effect, or was there any? Did you notice any positive changes? Because in one community, maybe you had health advocates, and in another community, you did not have health advocates. So, do you have any experience with that?
Yes, I can answer directly from my experience, because just by chance this activity has been of great importance in raising awareness in the health sector, but also at the political level, of the mental health consequences of the epidemic. Because, as you may imagine, in early stages, all the energies are devoted to stop the epidemic, and everybody works in infectious wards or internal medicine or in emergency and so on. But many associations, many advocating groups have worked, and incidentally, in the next few days, on Saturday afternoon, there will be in Italy a national assembly of this association. I have been invited to speak with them to give political decision makers an insight on mental health consequences of the epidemic, but also a more complete view of what will happen after. Because, as I told you, now we are in a better situation as compared with 1 or 2 months ago from the infectious diseases point of view. But we are at the beginning of one of the hugest socio-economic crisis since the World War II. And as everybody knows, this is another more powerful stressors on mental health and well-being of population. So everybody needs to be aware that this will be the main problem in the next future.
Thank you so much, Dr. Fabrizio. Thank you so much to the rest of the team. We really do appreciate you taking your valuable time to speak to us and to offer guidance. Here we were thinking COVID-19 and the effects on mental health would be the greatest challenge. but now we have to start preparing ourselves for the even greater challenge of economic hardship that is coming because of the lockdown and the effects around that. So thank you for keeping us on our toes already, although we're getting really barely started here. So we really do appreciate you, Dr. Giovanni, Dr. Fabrizio, and Dr. Maria for this session. I guess we can also reach to you bilaterally because our colleague is asking about training materials that you can share with us. So maybe we will just get to you on email on that. So really just thank you from the team here in Addis Ababa and from other regions that have tuned in. Really, really appreciate. And this was really a valuable learning opportunity for all of us. Thank you very much. And who knows, we should probably make it a monthly thing. We can discuss that with Laura at some point. So thank you very much. And we look forward to the information that you'll be sharing with us, especially the slides that you have all shared, so that it can continue to be a benefit even to those who did not make it to this call today. Thank you very much. Laura, back to you.
Bye. Bye.
Thank you, Teresa. Thank you to you and to all the team, and have a good time and take care. Bye.
Okay,
Thank you. Laura, are you there?
yeah, I would like just to finally say thank you to WHO, of course, for setting up the meeting. Thank you for the active participation of all of the attendants. So I hope you will spread out all the information that you have collected today, because it's very important to keep everybody informed. And let's say that it's really food for thought. So let's make it fruitful. And at the end, really a big thank from my side on behalf of the Italian cooperation to all the 3 doctors that have been today with us and ready, and for really at the beginning always very available, and in sharing all this information experiences, even in this critical moment that everybody is now living. So let's keep in touch, and thanks again.
Thank you.
Thank
Thank you so much.
Bye.
Take care.